This recorded review will be going over the study guide for Med-Surg 1, Exam 2, covering Chapters 7 and 9 in the Med-Surg textbook and Chapters 12 and 20 in the Introduction to Clinical Pharmacology textbook. Chapter 7. Who determines the standard of pain as well as pain control? We can see that answer on page 132. The patient is the only one with the first-hand knowledge of their pain. Their report of pain needs to be used for management decisions, as do all other pain data. Pain is to be assessed every time vitals are taken, or more frequently if indicated, by asking the patient to rate any pain and describe its characteristics. The standard of pain and pain control is determined by the patient. Describe the gait control theory. We can see a bit more of that on page 127. It may be helpful to think of pain as being controlled by a gate in the central nervous system. When the gate is open, the pain sensation is allowed through. When the gate is closed, the pain sensation is blocked. The gate control theory recognizes that stimuli other than pain pass through the same gate. When a large volume of non-painful stimuli are competing for the same gate, pain impulses may be blocked. How does culture influence a patient's perception and display of pain? We can see a bit more of this on page 130. A person's cultural background influences feelings about pain. In much of Western culture, it is considered desirable to have a high pain tolerance, particularly among men. Other cultures promote the idea that to endure pain is natural or honorable. Your role as the nurse is to develop a therapeutic relationship with the patient that allows them to express their thoughts, fears, and beliefs regarding pain. The patient may have a stoic affect due to their culture. What occurs during the perception phase of nociceptive pain? What pharmacological interventions could the nurse try during that phase? So we can also see that on page 130. Perception is the third phase of nociceptive pain. It occurs when impulses reach the brain and the pain is then recognized. During the perception phase of nociceptive pain, the nurse should try to distract the patient by discussing family hobbies, and discharge planning. Pain is classified as nociceptive and neuropathic. Which of these categories would phantom pain fall into? Phantom pain would fall under neuropathic pain. Neuropathic pain can be seen on page 130 as well. It's associated with a dysfunction of the nervous system that involves an abnormality in the processing of sensations. Pain threshold versus pain tolerance. Define and differentiate. We can also see this on page 130. Pain threshold is the point at which pain is perceived. Pain tolerance is the length of time or the intensity of pain a person will endure before outwardly responding to it. Your patient is post-op day 1 and in severe pain, 8 out of 10. When you offer them the PRN opioid in their MAR, they say, "I'm just so scared to become addicted to pain pills and I'm afraid to take it." What is an appropriate response from the nurse? We can see some information on this on page 137 in the patient teaching blue box about managing pain. Take medication before pain is severe and take the medication regularly until the pain is well controlled before lengthening the time between doses. Use distraction, imagery, or relaxation exercises to augment the effect of the pain medication. We can also see a bit about this on page 137 as well in table 7.4, false perceptions of pain. Addiction to pain-relieving drugs is always a hazard, and for the sake of the patient, the nurse must often withhold a drug even though the patient asks for it. That is a false perception. The fact is that a very small percentage of patients, less than 1% and no more than 3%, so fewer than 3% of patients, become addicted to drugs administered for the purpose of relieving acute pain. Although addiction is an increasing problem in the United States, acute pain can be managed properly, and it is not the reason for the increase in our opioid addiction. Patients do need adequate pain relief. What needs to be included when documenting regarding a patient's pain? Be aware of good and poor charting examples. So we can also stay on the same page 137 for a bit of documentation. All measures to control pain need to be documented accurately, including the initial pain assessment. Document aggravating and alleviating factors. This would include your location, intensity, duration, and method used to assess the pain. Any measures taken to alleviate that pain. Evaluation of the effectiveness of those measures. Any provider notification of any problems or concerns, including the provider response, and any related patient or family education that was provided to them. We can see a good example of patient documentation on page 138 under the heading of Example of Pain Documentation. It is important to manage pain when it's at a lower level compared to letting it rise to a severe level and then attempting to treat it. How can we educate our patients on this concept? So again, just go back to page 137, take a look at those false perceptions of pain in table 7.4, as well as that blue patient teaching managing pain box that I read a few minutes ago. What is the process for placing/removing transdermal analgesic patches? What if a patch falls off before it's scheduled to? We can see a bit of this on page 139 and look at the clinical cues in the purple box. Always remove the old transdermal patch before applying a new one. Cleanse the skin where the old patch has been. The patch must be removed before the patient undergoes an MRI to prevent any burn from a foil in the patch. If the nurse notices that a transdermal patch falls off before it's scheduled to be removed, you should document the loss and apply a fresh patch. A patient is receiving frequent doses of opioids and begins to complain of constipation. What intervention should the nurse try first? What additional interventions could be tried after that? So let's take a look on page 141. Probably the most common and one of the most distressing side effects of pain medication is constipation. Analgesics such as morphine, hydromorphone, and oxycodone will slow peristalsis. Fecal material becomes compacted and dry due to the extended time needed for passage through the intestines. Measures to prevent constipation should begin with the first dose of the medication. The first thing you should do is increase the oral intake. Oral fluids must be increased if possible. Stool softeners and fiber-based laxatives, such as Metamucil, can also be helpful if approved by the healthcare provider. Miralax has often also proven effective for opioid-induced constipation. Prescription medications for this are also available when over-the-counter remedies are ineffective. Help prevent constipation in your older adult patients who are receiving opioid analgesics by encouraging them to increase their intake of fluids and fiber, administering any stool softeners, suggesting prunes or prune juice, and monitoring for any bloating, discomfort, and a lack of a daily bowel movement. So the first thing you should do is increase the oral intake. A patient finds cold application helpful for their pain. How should they be instructed to use the ice pack? We can see the answer to this on page 142 in the purple clinical cues box. The effectiveness of cold is maximized in 15 to 20 minutes. Remove the source after that time. How does sleep contribute to a patient's tolerance and healing process? We can also see that on page 142. Adequate sleep and rest are major factors in healing. Rest will increase pain tolerance and improves the response to analgesia. When can distraction be an effective intervention for pain? We can also see that on page 142. Distraction can be helpful in bridging the time gap between giving an analgesic and the onset of pain relief. Describe the placebo effect. If a placebo is effective, does that mean the patient was pretending to be in pain? We can see this by going back to table 7.4 on page 137. Placebos are very useful in assessing whether or not a patient has pain. That is a false perception. The fact is that there is no basis for believing that a patient who finds relief from pain after receiving a placebo has been pretending to have pain. A sufficient study of this subject has shown that actual pain can sometimes be well relieved by placebos. The patient could be relieved of the anxiety that there is no actual source of the pain remedy. So no, it would not mean that they were pretending necessarily. The nurse administers 2 milligrams IV morphine PRN for pain to a patient. 15 minutes later, the patient is itching uncontrollably and breaking out in hives. What is the nurse's next action? We can see this on page 141. Allergic reactions, such as itching and hives, need to be reported immediately. Discontinue the medication and obtain an alternative order. The patient may need an antihistamine, such as Benadryl, for relief of their itching. Your patient's caregiver asks about the use of massage for pain relief. What education can you provide them? We can see this on page 143. The use of long, firm strokes, short, soft, circular strokes, and occasionally gentle pounding with the sides of the hands can stimulate circulation, relax muscles, and increase the general sense of well-being. When the painful area has inflammation or consists of a wound or an incision, massaging another area of the body with gentle but firm pressure can help the patient direct their attention away from the pain. You should avoid areas of inflammation. Chapter 9, Chronic Illness and Rehabilitation. Disability versus impairment, define and differentiate. We can see this on page 183. A disability is linked to a person who has a condition or quality that is present when common activities such as walking, talking, reading, or learning are restricted. Some disabilities, such as blindness or hearing loss, are apparent to others, whereas others, such as chronic depression, are not. The term impairment refers to the dysfunction of a specific organ or body system. What are some interventions to prevent falls? Multiple questions on box 9.5, page 189. So go ahead and take a look at that box 9.5 on page 189. Be sure to choose a chair with sturdy arms to aid in rising, and always utilize a gait belt whenever possible. When planning care for residents, we want to allow the resident to maintain or achieve as much autonomy as possible. Older adults are at a greater risk of complications due to immobility, even if they are only immobile for a few days. What are some additional assessments pertinent to those situations? We can see the answer to this on page 183. Evaluate each patient's situation and determine whether the patient is at risk for problems related to their decreased mobility. Even if the patient is going to be immobile for only a few days, measures need to be taken to prevent any secondary problems. Patients with disorders causing decreased mobility need to be assessed for the degree of risk for the various associated problems, and then interventions to prevent those associated problems need to be initiated. Early effects of decreased immobility include a decrease in muscle strength, generalized weakness, easy fatigue, joint stiffness, decreased coordination, abdominal distension, risk for VTE, and various metabolic changes that are detectable by laboratory testing. Decubitus ulcers are a serious complication of immobility. How can the nurse work to prevent this complication? We can see the answer to this on page 188 in box 9.2, the Joint Commission's National Patient Safety Goals. Prevent healthcare-associated pressure injury, decubitus ulcers. To prevent this, we need to perform a skin assessment at admission and identify any patients or residents at risk for a pressure injury. You should participate in agency pressure injury prevention activities regularly, including turning Q2 hours. Also see on page 188 in the bolded text. When planning care for residents in a long-term care facility, the LPN must keep in mind that the overall goal of care for the facility is to provide a safe environment, assist the resident to maintain or attain as much function as possible, promote individual independence, and allow the resident to maintain or achieve as much autonomy as possible. And those are the overall goals of the long-term care facility on page 188 for the next bullet point. How does diuretic therapy contribute to patient falls? How can the nurse plan patient care to minimize that risk? So we can see that on page 189. A resident who is receiving diuretic therapy needs to be assessed frequently for any fluid and electrolyte imbalance that could cause weakness, dizziness, or confusion. Residents on diuretic therapy need to receive prompt assistance for toileting whenever assistance is requested. And see the safety alert in the red box on this same page 189. Medication assessment. Assess all medications a resident is taking to determine the risk of medication-induced postural hypotension or dizziness. This can contribute to falls. Don't forget to include over-the-counter and herbal medications, as well as any prescription medications, especially diuretics. How often should the need for a security measure be assessed by the nurse? We can see this on page 191 in box 9.7, principles related to the use of security and safety devices. You should reassess the need for the security measure every 4 to 8 hours. What is an appropriate intervention for an older adult who suffered a major loss of body function and who is not receptive to rehabilitation efforts? We can see this on page 193 in the red older adult care points box. An older adult patient who has suffered a major loss of body function may not be initially receptive to rehabilitation efforts. It takes a skillful nurse to help motivate the patient to want to improve their functional ability. Sometimes introducing the patient to someone close to their own age who has been through a similar illness and managed to regain some of their functions is the best medicine. Gentle encouragement with praise for small efforts and accomplishments is better than trying to force a patient to perform exercises or practice a task. What is an appropriate intervention for the disoriented older adult in long-term care? We can see this on page 190. Consistency in meal times, scheduled activities, treatments, and daily personal care routine can be helpful. Do not overwhelm the resident with options, but allow them to choose their preferences during these activities, and family members can be very helpful here. A time schedule for activities and events within the facility should be posted in large type where the resident can refer to it frequently. What healthcare practice settings focus on people with chronic illnesses and disabilities? So we'll go all the way back to the beginning of the chapter for this, to page 182. Patients with chronic illnesses and disabilities are cared for in a wide variety of practice settings. As an LPN, you may have the opportunity to care for patients in long-term care facilities, rehabilitation facilities, outpatient clinics, primary care settings, and even at home. What are the goals for rehabilitation? Back to page 193. A primary goal of rehabilitation is to minimize the deficit from the condition and maximize the abilities that are intact. It will involve measures to achieve the highest possible levels of physical, emotional, psychological, and social functioning and well-being. Rehabilitation is concerned with achieving a better quality of life. Rehabilitation programs have a philosophy that is based on 3 beliefs. Each person is unique, whole within themselves, and interdependent within their own environment. Independence can be achieved within the limits of the disability when the person is a full participant in managing their own life. The goal is to enable patients to mobilize their own resources, choose goals, and attain those goals through their own efforts. So overall, the goals of rehab are to promote new coping skills, teach adapted living skills, focus on self-care, increase independence, and improve quality of life. How does a diagnosis of disability impact a patient's life? We can see this on page 183. When chronic illness causes the loss of function, usual roles can be changed. Changes in a person's role will affect the family as well. Daily patterns are altered to accommodate treatments and therapy and to cope with the problems of the disability. Spiritual distress may be experienced as the person is faced with limitations of their illness or disability that has occurred. Patients with chronic illnesses and their families may feel powerless, especially during the phases of diagnosis and early treatment. Support for the patient's usual coping techniques and teaching new ways to cope can help the patient effectively deal with their illness and the changes in their life patterns that it brings. Be instrumental in instilling hope for a good quality of life and in fostering resilience despite the illness. Also take a look on page 184 in both of the red older adult care points boxes. Although many older adults are active in their daily lives, some older adults may not be able to engage in regular physical activity. When their mobility is decreased, muscle strength and flexibility are diminished due to disuse. It is much more difficult for these patients to then regain their mobility. Assess these patients daily. Look closely at each body system in which a problem related to decreased mobility may occur. It's important to recognize signs and symptoms of each type of problem and understanding how to intervene or to decrease or prevent those problems. The assessment details and nursing care for each problem are discussed in this chapter. Older adults are a greatly increased risk for problems of decreased mobility due to the changes in their various body systems that normally occur with aging. Monitor them closely for any pressure sores, as well as hypostatic pneumonia, constipation, urinary problems, and inadequate nutritional intake resulting due to their lack of appetite. Attention to range of motion exercises is also very important and often neglected. Chapter 12, Drugs for Pain Management. Which drugs have the main purpose of relieving pain? We can see this on page 224. A wide range of drugs are used in managing pain. Some of these drugs are actual analgesics. These are drugs that have the specific purpose of relieving pain by changing a patient's perception of the pain or by reducing the painful stimulation at its source. Who can measure pain? We can see this on page 221. Because the sensation of pain is felt only by the person experiencing the pain, it can be measured only by the individual person experiencing it. The nurse is caring for a paraplegic patient with a stage 3 decubitus ulcer on their left heel. When questioned about the pain, the patient rates their pain as a 0 out of 10. Explain this. Take a look at page 222. You perceive pain only in the brain, and anything that interferes with the transmission of the pain signal from your toe along the nerves to and within your brain can change how and whether you perceive that pain. So if you had a stroke that damaged the part of your brain where toe pain would be perceived, you would not feel that pain. If the pain nerve tracts in your spinal cord were severed, you would not feel the pain in your toe, even though the injury would be severe. Also, if the nerves in your leg were severed, the pain signals would not reach the brain and you would not feel the toe pain. Why are natural and synthetic opioids considered high alert drugs? We can see this on page 225. All natural and synthetic opioids are high alert drugs because they have an increased risk of causing patient harm if given in error. What is a nursing implication when administering opioids to patients regarding their respiratory status? We can see this on page 226 in table 12.3, examples of common opioid agonists. Assess respiratory rate and pulse oximetry frequently because opioids can cause respiratory depression. If patients cannot be aroused, have respirations below 8 breaths per minute, have severe hypotension, or develop hypothermia, you must notify the healthcare provider immediately to prevent coma or death. What patient teaching needs to be included for a patient being discharged with an opioid prescription to prevent constipation? We can also see this on page 229. The patient should be educated to increase their fluid and fiber intake to prevent constipation. How does tramadol work? We can see this on page 230. Tramadol has only weak effects at opioid receptors. Instead, it works by blocking or inhibiting the action of some neurotransmitters in the spinal cord and areas of the brain. This reduces the pain signal transmission to areas of the brain that perceive pain. What is an adverse effect of acetaminophen? We can see this on page 231. Although acetaminophen is available without a prescription, it can have some serious adverse effects. When taken at higher doses or for prolonged periods of time, acetaminophen is toxic to the liver, resulting in liver damage. The potential for liver toxicity is why there is a maximum total daily dose for this drug. For a patient experiencing acute pain, how should their pain management be scheduled? We can see this on page 226 in that same table 12.3. During periods of acute pain, encourage the patient to take the drug on the prescribed schedule for the best pain relief. Assess elimination status daily because all opioids can cause constipation. Why do we assess cardiovascular status more frequently in a patient who is newly prescribed cyclobenzaprine? We can see this on page 223. Common side effects of cyclobenzaprine are dizziness, headache, dry mouth, blurred vision, and urinary retention. Serious adverse effects of cyclobenzaprine are cardiac dysrhythmias and prolonged cardiac conduction. Also seen in table 12.5 on page 233, the nursing implications for cyclobenzaprine. Before giving the first dose of either skeletal muscle relaxant, ask whether the patient has a seizure disorder because these drugs will lower the seizure threshold. Why do we assess urinary status more frequently in a patient taking methocarbamol with a history of prostate issues? We can see this on page 234. Methocarbamol and cyclobenzaprine can cause urinary retention. If a patient who is receiving one of these drugs has an enlarged prostate gland or is also taking a drug for overactive bladder, assess them for signs or symptoms of urine retention. Symptoms would include difficulty starting the urine stream, a weak urine stream, and a bulge in the lower abdomen. Also see on page 234. Before giving the first dose of cyclobenzaprine, assess the patient's blood pressure and radial and apical pulses for any skipped beats, extra beats, or other type of irregular heartbeat. Assess the patients for cardiac irregularities before giving cyclobenzaprine. If you find any persistent heartbeat irregularities, notify the healthcare provider before you give the drug. What are the 4 strong opioid analgesics? We can see this on page 226 in the orange box. Strong opioid agonist analgesics would include the following: morphine, hydromorphone, oxymorphone, and fentanyl. Which 2 categories of drugs act in the tissue to relieve pain rather than changing a person's perception of their pain? That would be NSAIDs, and we can see that on page 232. NSAIDs are non-opioid analgesics that have the main action of reducing inflammation. NSAIDs can help manage pain associated with inflammation, bone pain, cancer pain, and soft tissue trauma. Like corticosteroids, NSAIDs actually act in the tissue where pain starts and do not start a person's perception, stop or change a person's perception of the pain. We can also see corticosteroids on page 232. Corticosteroids are drugs with powerful anti-inflammatory actions that are chemically similar to the glucocorticoid hormones secreted by the adrenal glands. These drugs are able to greatly inhibit the production of mediators that results in actions and symptoms of inflammation. What are some miscellaneous drug categories for pain management? So some miscellaneous drug categories that we can use to help pain management would include antidepressants and anticonvulsants, as well as corticosteroids, NSAIDs, skeletal muscle relaxants. So you can see those on page 232 through page 234. The nurse gives a patient their prescribed PRN opioid for pain relief. What steps should the nurse include to follow up after administration? We can see this on page 228. Usually, opioid agonist analgesics will begin to take effect in 15 to 30 minutes. Check the patient at that time for pain relief and for any changes in their respiratory rate and depth. Recheck them at least every hour. Opioid agonist analgesics can slow the respiratory rate and decrease the cough and sigh reflexes. Patients who have had surgery, especially those who have smoked for a long time, may develop areas where the lungs do not inflate well or where fluid can collect and pneumonia may develop. If pain relief is not obtained or if it's not sufficient to keep the patient comfortable, report this to the prescribing doctor so that changes in pain management can be made. Higher doses and/or frequent dosing may be needed. If the patient has been receiving an opioid agonist for 2 days or longer, you should ask them about constipation because this is a very common side effect of these drugs. If stool softeners or laxatives have been prescribed, you should give them as ordered. Chapter 20, Over-the-Counter Drug Therapy. Can over-the-counter drugs interact with other drugs, food, and alcohol? Yes, absolutely they can. We can see this on page 365. Over-the-counter drugs often interact with other drugs and with food or alcohol, or they may have an effect on other health problems that you might have. You should ask a pharmacist if you are unsure about any interactions. Why should the nurse caution the patient against buying over-the-counter drugs online? We can also see this on page 365. Avoid buying these products online outside of well-known internet insurance company sites, because many over-the-counter preparations sold over the internet are counterfeit products. They may not be what you ordered, and they could be dangerous. What should the nurse include in the patient teaching for patients interested in buying over-the-counter medicine for their child? We can see this on page 366. Do not give children a drug that contains alcohol. Does the FDA regulate herbal and dietary supplements? We can see this on page 367. Producers of dietary supplements are responsible for ensuring that their products are safe. However, they don't have to provide the FDA with information that demonstrates the safety of the product before they can market it. If a claim is made about the effects of a dietary supplement, the producer needs to have data to support that claim. Any claim about how the supplement may affect the body needs to have the following statement on the label. This statement has not been evaluated by the U.S. Food and Drug Administration. This product is not intended to diagnose, treat, cure, or prevent any disease. So the FDA does not regulate herbal supplements. Is it safe to take over-the-counter drugs that have expired? No, it is not. We can see this on page 365. You should throw away drugs that have expired. That means they are older than the date on the package. Why should nurses caution patients against using St. John's wort? We can see this on page 369. St. John's wort, ginseng, and golden seal are common herbal products that are most likely to cause dangerous interactions with many prescription drugs. Do people generally take multivitamins because they're prescribed to them or just because they want to? We can see this on page 369. Most people who take vitamins decide to do so on their own without the advice of a healthcare professional. A patient tells the nurse she is taking extra doses of vitamin C to kick her cold faster. Why is this not an effective strategy? We can see this on page 373. Excessive doses of vitamin C are usually rapidly excreted into the urine. Your patient asks you if they should spend the extra money on the expensive organic vitamins. What is your response? We can see this on page 371. Advertisers suggest that natural products are better than synthetic vitamins. The human body processes vitamins in the same way, whether they are natural or synthetic, costly or cheap. The most important differences are that some preparations may dissolve better than others, or may contain the active product in amounts that increase the absorption of other vitamins and minerals taken at the same time. Why should pregnant women be cautious about the amount of vitamin A they're consuming during their pregnancy? We can see this on page 371. Pregnant women should not receive more than 1,300 micrograms daily, or they may risk fetal abnormalities. What are signs and symptoms of vitamin A overdose? We can see this on the same page. Early indications of vitamin A overdose are anorexia, or lack of appetite, abdominal pain, malaise, and yellowing of the skin, especially on the nose and ears. Why is IV thiamine administered in a glucose-containing solution to ETOH patients? We can also see this on page 371. If giving thiamine to an alcoholic or a thiamine-deficient patient, IV glucose should also be given to prevent the precipitation or worsening of Wernicke's encephalopathy. Name some food sources that are high in riboflavin. We can see that on page 372. Teach patients that common food sources of riboflavin would include dairy products, eggs, green leafy vegetables, organ meats, and peanuts. Warn patients that riboflavin supplements can turn urine a deep yellow color. What are some side effects of niacin? We can also see this on page 372. When taken with beta-blocking drugs and calcium channel blockers for hypertension, the side effects of niacin can increase, especially skin warmth, flushing, and blood vessel dilation. This effect can lead to postural hypotension. If dizziness occurs with niacin, tell the patient to sit or lie down. Who is at risk of pyridoxine deficiency? We can also see this on page 372. Pyridoxine deficiency is most likely to develop in the older adult population and in women of childbearing age, especially those who are pregnant or breastfeeding, women who are taking oral contraceptives, individuals who are alcoholics, and those whose diets are poor in the quality and quantity of protein or high in refined foods are also at risk. Why is folic acid so important for women of childbearing age? We can also see this on page 372. Guidelines emphasize the importance of increased folic acid intake by all women of childbearing age, especially those who are intending to get pregnant and during early pregnancy, in order to help prevent spinal cord malformations in the fetus or neural tube defects. Who is at risk of developing a vitamin B12 deficiency? We can see this on page 373. Most patients with a vitamin B12 deficiency have a malabsorption problem in the GI tract, pernicious anemia, or alcoholism, or are on a vegan diet. How should vitamin C be stored? We can see this on page 374. Vitamin C is easily destroyed by air, heat, and light. This drug should be kept tightly capped in its own container. Foods high in vitamin C should not be boiled for long periods or left uncovered in the refrigerator. What are the uses of vitamin E? We can see this on page 375. Many suggested uses of vitamin E are controversial and unproven. The only established use is to prevent or treat vitamin E deficiency, which is rare in the United States and is usually the result of an impaired metabolism. Vitamin E has been touted as a powerful antioxidant and can play a role in reducing heart disease as well as atherosclerosis. Vitamin K is an antidote to blank toxicity. Vitamin K is an antidote to warfarin toxicity, and you can see this on page 375. Vitamin K does not counteract with the anticoagulant activity of heparin, although it is helpful in reversing the effects of warfarin or Coumadin overdose.